All right. Hello, everyone. I warmly welcome you all on IASNM MISSI webinar series, and I wish you all on behalf of IASNM MISSI a very happy new year. And a little bit about these webinar series. So it's going to be a 45-minute session, followed by 10 to 15 minutes of Q&A. Kindly please mute your devices during the talk. And you can you can put in your questions in the chat box, and we'll address it in the order that they were received. And you can also live ask questions at the end of the session. Now, it's my pleasure and honor to introduce Dr. Amar Kishan, who is the professor and vice chair of clinical and translational research and chief of genitourinary oncology services for the Department of Radiation Oncology at David Geffen School of Medicine at UCLA. Dr. Kishan graduated from University of California, Berkeley. He earned his medical degree from Harvard Medical School, where he graduated magna cum laude from the joint Harvard-MIT Health Sciences and Technology program. During medical school, he was awarded Harvard Hughes Medical Institute fellowships to study tumor metabolism in the lab. He subsequently completed his internship training at Scripps Mercy Hospital in San Diego, where he was recognized as the H.A. Jones Intern of the Year. He's completed his radiation oncology training at UCLA. Dr. Kishan specializes in the utilization of radiation to treat genitourinary malignancies. He has an extensive research background and has published over 200 manuscripts in leading journals. He has received extensive grant support, including funding from the Department of Defense, the Prostate Cancer Foundation, the American Society of Radiation Oncology, Radiation Oncology Institute, and the Johnson Comprehensive Cancer. He runs an active clinical and translational research program and has spearheaded multiple innovative clinical trials in radiation oncology. Dr. Kishan.
Well, thank you very much for that kind introduction and the invitation to present today. Hopefully, the talk will be useful for you all. So I'm going to start with some brief notes about the different types of PSMA-based tracers as well as IASNM. Then I'll go over kind of the high-level evidence for PSMA for initial staging, and then talk about advanced imaging for post-prostatectomy recurrences. And there should be ample time for questions at the end. Again, as a caveat, I'm a radiation oncologist, and I know many of you are coming more from the nuclear medicine bent, so you may know much more about the technical aspects of imaging than me, but hopefully it's still of use. So as we're kind of all aware, there are some foundational changes recently, since basically 2016 or so, in prostate cancer imaging. First with the approval of fluciclovine or Axemin in 2018, and then subsequently gallium-68 PSMA late 2020, and then Pylarify or 18F PSMA in 2021 or early 2022. And these are basically harnessing modalities that are specific, or at least more specific, for prostate cancer. As you can see, fluciclovine, an amino acid-based tracer, maybe a surrogate for prostate cancer metabolism, and PSMA, a prostate cancer specific membrane antigen, and a protein that's transcellular. And you can see that many of these tracers are antibody conjugates targeting the extracellular portion of this protein. In terms of the data, I think the field has actually done a pretty good job of high-level multi-center prospective data in various settings for the different tracers. And so if we kind of consider, maybe there's 4 tracers as of now in 2024. We have Axemin, we have gallium-68 PSMA or Locomets, we have Pylarify, and most recently we have Posluma. We have different phase 2 to 3 data in the upfront setting for most of the PSMA tracers. In BCR setting, we have phase 2 to 3 data for all of the tracers, and we do have randomized phase 3 data for fluciclovine in the recurrent setting, in the pre-salvage radiation setting, and we have the pro-PSMA trial from Australia in the intact setting. So I think overall we should kind of congratulate the field for executing these level of study, for these different types of tracers. I don't think that's been done in many other types of imaging modalities for many different types of cancers. So good for us. In terms of some radiochemistry, again, probably you all are much better qualified to speak to this than me, and you probably already know all this, but the F-based PSMA tracers have a higher SUV max and a slightly higher detection rate. They have higher positron yield, lower positron energy, leading to shorter positron range and better signal-to-noise ratio, and has a longer half-life in general than the gallium-68 tracers. So for these reasons, for kind of a mass production, widespread adoption, 18F-based PSMA tracers, which would be either Pylarify or Posluma, are likely more appropriate than gallium-68. I can give a brief discussion. At our center, UCLA, we still use the gallium-68 pretty frequently at our main site, mainly because we've invested heavily in it. We have the capacity to synthesize it and run that, and we've been doing that for many years. But at many of these satellite sites within the UCLA network, we have moved to using Pylarify. We're in discussions about whether bringing in Posluma or not. We have not yet brought that in routinely. In terms of tracer choice, there is one randomized trial published in European Urology late last year that compared an 18F PSMA-based tracer versus gallium-68 PSMA in 82 patients with primary or recurrent disease. And per patient, the proportion of positive scans rated by 3 liters were actually similar, with a higher PSMA expression, but possibly higher false positive in bone with the 18F PSMA 11 tracer. And the overall conclusion was that either scan is appropriate. It does appear, again, my experience, that the 18F PSMA may be a little bit more sensitive slightly, although with expert readers, I think, you're still okay with the gallium-68. But with that higher sensitivity, there may be a slight increase in false positives. All right, so let's go over some of the data for PSMA and initial staging. So obviously the highest level data comes from the Pro-PSMA trial. This was a multi-center trial in Australia involving 302 men. Sorry, 1 second here. Okay, with high-risk features. It did include Gleason grade group 3 to 5. So Gleason 4+3 would be included here, which is traditionally an intermediate risk feature, but other characteristics, PSA greater than 20 or T3 to 4, randomized to receive conventional imaging, CT abdomen, pelvis plus bone scan, or upfront gallium-68 PSMA scanning. All patients had crossover imaging within 14 days unless there were obvious metastases, more than 3. At 6 months, patients underwent repeat imaging per original randomization with crossover if initial staging was N1 or M1, or if there was a recurrence. The primary endpoint was accuracy of first-line imaging for identifying N1 or M1 disease. That's defined as the area under the curve. The reference standard was determined by the site PI. This was a multi-center trial. But essentially, there were hard criteria, of which one was necessary, and that's histopathologic confirmation or a bone lesion that became sclerotic or blastic on follow-up. And there are multiple soft criteria, of which more than 3 were needed. This included patient receiving treatment for that imaging finding, which is a pretty soft criteria if you think about it. But again, you needed 3 of those. They also checked the incremental accuracy of second-line imaging. And one other side note, these slides I think will be made available to you. So some of the slides may be slightly dense. That's more that this is a kind of good review material for you to go back and look at. Obviously, a lot of information with this study. So what I'm showing you here are the primary endpoint results from this trial. So the primary analysis, I'll draw your attention to those forest plots, looking at the AUC for PSMA versus conventional imaging first, PSMA in blue, conventional imaging in red. And you can see clearly that, overall, with pelvic nodal disease specifically, or with distant metastasis specifically, the AUC significantly better with PSMA upfront. The specificity is pretty good with conventional imaging. So there's not too much of a difference there, although numerically slightly better with PSMA. The sensitivity, again, far exceeds conventional imaging, again, whether it's any metastatic disease, pelvic nodal disease, or distant mets. Now, there were more equivocal findings seen with conventional imaging. 30% of patients had node positive or metastatic disease when using a reference standard to evaluate kind of overall. And of these, 23%, so about 7% of all patients, were verified by hard criteria. So, most of the disease seen here in terms of, calling spread were defined and verified by soft criteria. So just keep that in mind. But that's a practical limitation. It's hard to get a biopsy on all of these patients. If we look at the lesion distribution, it makes sense with what we would expect with spread of prostate cancer. You can see with bony lesions, the majority are in the axial skeleton, pretty low proportion, but 1%, 6% in ribs or long bones, and maybe about 2% clavicle, scapula, sternum. And the vast majority of nodes are pelvic, about 7% periaortic, paracaval, and 3% in the supraclavicular area, or diaphragmatic in general, mainly supraclavicular. When we look at management effect, whether there's kind of a change in first-line diagnostic imaging or second-line diagnostic imaging, again, having the PSMA leads to more significant changes in management. And because of this, because of the fact that if you got a bone scan, then you get the PSMA, you're likely going to change management in a fair number of patients, whereas the other way around, that's very unlikely. It ends up that patients that get the PSMA first actually have less radiation exposure, and that's on the bottom there. So the dose in millisieverts is actually less for patients that are getting PSMA up front, which could be an argument to just routinely use the PSMA. So in summary, PSMA had superior diagnostic accuracy, both sensitivity and specificity, than conventional imaging, and that leads to more management changes with less overall radiation dose, superiority for both the nodal staging and metastatic staging. But the caveats are that this was a broad patient population. Having just lesion grade group 3 disease, which would be, again, a 4+3, was sufficient for inclusion, and maybe that diluted the results a little bit, or maybe not. Maybe the conventional imaging would have performed better in a population enriched for higher risk disease. There's also lack of confirmation with harder criteria for the vast majority, of over 73% of the called extra prosthetic lesions. We also, have the UCLA UCSF PSMA phase 3 trial. So this was done for registration for gallium-68 PSMA. So this was obviously 2 centers enrolling 764 men, and I enrolled patients on this study, so I can speak to it a little bit more. But essentially, these are patients with intermediate risk or high risk disease that are planning to undergo surgery, that are kind of offered a PSMA, if they enroll on this trial. Ultimately, 36% of them went through with the radical prostatectomy, and that's a key. So it was a planned to undergo radical prostatectomy. There may have been patients that kind of enrolled on the trial purely to get the PET without having an intention to get a PSMA. Those are kind of some of the nuances that may be there. The trial was powered to detect nodal disease increase from 42% to 65%. Of the patients that had surgery, about 27% had PN1 disease, and 14% had IN1 disease, with some evidence of metastatic spread in about 4% of patients. So overall, the sensitivity was a little low at 0.4, but the specificity was quite high, 0.95. Positive predictive value and negative predictive value are fairly reasonable at 0.75 and 0.81, respectively. Now, a couple of notes. Many of the false positive PSMA scans actually did have PSMA persistence after surgery. And so this would be an instance where, there's a node in the pelvis, they get a node that's actually negative, but then they have persistent PSA. And in some of those cases, it actually is just that the node was missed. So that's not really a true false positive. So that's one thing. For nodes greater than 1 centimeter, the sensitivity was actually 0.6, so a lot better. The major technical feature that was strong and has been used in subsequent studies was the use of 3 blinded independent readers. But I think one key point, and I touched on it before, was that the PSMA results were not blinded. One way to think about it is this was a way for patients in the US at these 2 institutions to get a PSMA that was otherwise not available, right? So not everyone was going in thinking they're going to get surgery for sure. And the results were unblinded. So 52% of patients that got a PSMA at all had node positive disease, at least by imaging. And many of those patients decided to not go through with surgery. So that also affects the sensitivity, because you have maybe a smaller volume disease cohort that's going for the surgery. And in that cohort, there's less disease. And you can see that only 14% in the RP cohort actually had nodal positive disease on PSMA, as opposed to 52% overall. So these are things to keep in mind. The PSMA may actually have a better sensitivity than we think, since many of the positive results were filtered out. Now, the other kind of foundational study was the Osprey study, which was done for pylarify PET. This was a 2-cohort study, and I'll be talking about the first cohort, which included 252 patients with high-risk prostate cancer planning to undergo surgery. Histopath confirmation formed the backbone of the primary endpoints, which were sensitivity and specificity. Again, the sensitivity was only 40%, but the specificity was quite high. But for nodes greater than 5 millimeters, the sensitivity was 60%. And those numbers are almost identical to what was seen with gallium-68 in the UCSF-UCLA registration study. So, I think this speaks to the fact that, for small nodes, patients, planning to undergo surgery that have a, negative PSMA PET, yes, the sensitivity is not that high. Overall, all comers, sensitivity may be better. And for big nodes, the sensitivity is not bad. It's not perfect, but it's not bad, around 0.6. And just very recently, last year in October, we had the Lighthouse study, which was a registration trial for post-luma PET, 352 patients across 31 sites with unfavorable intermediate or higher risk prostate cancer. Ultimately, most of these patients had surgery, and again, they had 3 independent readers, and they used the prostatectomy specimen and lymph node dissection specimen as the ground truth. The performance goal was 22.5% for sensitivity and 82.5% for specificity as a lower bound of the confidence interval. In this group, about 25%, 24% had node-positive disease pathologically, and overall, a similar number had PSMA node-positive disease, and a fairly higher percentage actually had metastatic spread. And that may be because of the inclusion of more high and very high-risk prostate cancer patients. The sensitivity was pretty low in this study, 0.24, so that's a little bit worse than in the prior talk. The specificity was quite high, and the PPV and NPV were reasonable. Sorry. My kids are awake in the background, so that's what that is. Okay, so the post-hoc canal, we did a study looking at predictors of upstaging on PSMA to kind of help identify, maybe from the radiation perspective, which percentage of these patients, may benefit from a PSMA PET upfront if it wasn't widely available, or like what are the predictors, and what is the potential prognostic impact of being positive on PSMA. So we had a cohort of 213 men with a high-risk disease that had been enrolled on various prospective trials, including the registration trial at UCLA, who had M0 disease on conventional imaging. We found in that group about 21% had nodal upstaging, 9% had metastatic upstaging, and 24% overall had some form of upstaging. And that was significantly more frequent in men with Gleason grade group 5 disease and high volume disease. So we kind of made a custom nomogram to predict the risk of upstaging on PSMA. The overall goal actually was to apply this nomogram to a retrospective multi-institutional cohort of patients. Now, this is a big cohort across many institutions, US and internationally, where we knew what outcome patients had. We had long-term follow-up. So we could look at outcomes like BCR, distant metastasis, PCSM, and all-cause mortality. So what we did was we divided the cohort into groups based on their risk of PSMA upstaging. And the idea was, patients with a higher risk of PSMA upstaging, does that actually carry worse prognosis? And obviously this is all indirect, but it's going towards the idea, are we actually picking up disease that matters by picking up extraprostatic disease on a PSMA PET in patients that are M0, and should we be using something like that to maybe intensify treatment? What we found in this study was actually it was prognostic. So having a higher risk of upstaging on PSMA PET was prognostic of worse outcome, and it look at the split of these curves quite nicely across the different quartiles of risk of upstaging. So summary, PSMA detects more extraprostatic disease in patients with unfavorable intermediate risk and high risk disease than conventional imaging, and if widely available, should be a first-line test. The specificity is high. Known areas of caution are the ribs and areas near sympathetic neural ganglion. Sensitivity of PSMA, particularly for nodal disease, can be as low as 40%. And patients likely to have extraprostatic disease on PSMA are also likely to have a worse prognosis, implying these lesions are indeed of prognostic significance. Let's shift gears and look at the post-prostatectomy recurrence, the other major setting for advanced imaging. And I'll touch on fluciclovine here because it forms the basis of the only reported randomized trial. And so that's the Empire 1 study published in Lancet in 2021. So this is run out of Emory. 165 patients with detectable PSA after radical prostatectomy, no disease on conventional imaging. They were randomized to either no further imaging or a fluciclovine PET. It was designed to detect a 3-year progression-free survival increase from 50 to 70%. And progression was defined in a variety of ways. PSA of 0.2 higher than the post-radiation nadir, with another rise, persistence of PSA, or imaging evidence of failure. Using a modified intention to treat analysis, they excluded patients with extrapelvic or PET-avid disease that were not to receive radiation per protocol. That was the subject of some controversy. Certainly can talk about that in the Q&A. I think it was reasonable. Imagine being in this study and you get a PET scan that comes back that shows Axemin positive metastases. You might be reluctant to get prostate bed radiation, and it's not clear if it's fair to include those patients in the population. So I would say it's more of a feature of the study, not a bug. So the control arm received 64.8 to 72 point grade of the prostate bed with or without nodal radiation and with or without ADT. Experimental arm was very standardized. Extrapelvic or skeletal uptake, no radiation. Pelvic nodal uptake, radiation to the pelvis plus prostate bed. Uptake in the bed only, radiation to the bed, and no uptake, radiation to the bed. There was no boosting, no lowering of the whole prostate bed dose, but you could expand the standard volume to include PET-avid disease. So overall in this patient population, you can see that the PSA median was 0.34, so that's like an early-ish salvage population. ADT use was in about 2/5 of patients, about 40% of patients, and most of that was short-term. You can see the upstaging here. About 4 patients overall were excluded from the final endpoint analysis because they were found to have metastatic disease on Axemin. And again, people comment on that introduces some imbalance because there's, those patients would not have been excluded on the control arm. But again, that's probably part of the study. You could argue that's part of the benefit of doing this type of an analysis. In terms of other upstaging, there's actually a fair portion of local recurrences and a fair proportion of patients with a node-positive disease. When looking at the median follow-up report at slightly over 3 years, the median event-free survival was not reached, but the 3-year event-free survival was significantly improved in the experimental arm, and the 4-year was also significantly improved on multivariable analysis. Randomization arm, as well as whole pelvis radiation, high PSAs, and absence of ECE were predictors of event-free survival, and there's no difference in toxicity. So this kind of supports the use of fluciclovine, at least, to kind of help design radiation fields or expand radiation fields. I can speak from my experience. I'll give the next slide first. Comparing PSMA versus Axemin at UCLA, we did have a head-to-head trial. I enrolled a fair number of the patients on this trial. So it was basically gallium-68 PSMA versus fluciclovine in 50 patients with PSA 0.2 to 2.0 after radical prostatectomy. At the time, this was the only way patients in this setting could get a PSMA that was kind of covered. They wouldn't have to, pay a research. They wouldn't have to pay any fees for a research trial, and they didn't have to pay out of pocket for the study. And fluciclovine at this point was covered by most insurances, so it was fairly easy to enroll patients on the study. Median PSA was 0.5, and you can see that the overall detection rates were significantly higher with PSMA, so 56% versus 26%. Particularly with extrapelvic disease, much better with PSMA PET, and even with pelvic disease, 30% versus 8%. The only area where maybe there was a slight advantage to Axemin was in the prostate bed, and this is like 9 patients versus 7 patients, so it's not exactly a huge number. But this could be due to the different excretion, urinary excretion versus, GI excretion. And lesion uptake was higher with PSMA as well. So overall, this confirms that you really should get a PSMA PET, in my opinion. Now, the Empire 2 trial is ongoing, comparing PSMA versus Axemen in a randomized fashion. But I would say that this really changed my practice of just getting a PSMA PET in almost all circumstances. And we also had a prospective trial, UCLA UCSF trial of patients with recurrent prostate cancer after radiation, radical prostatectomy, or both. This trial was helpful in getting approval for gallium-68 PSMA. And something I always take away from this and explain to patients is this list of PSAs detection rates, because sometimes you'll have people getting a PSMA at a PSA level of 0.2 thinking it's going to show something. And we say, no, well, actually, even if you look at 0.5 and less, the detection rate was only 38%. It's helpful to guide patients and referring physicians as well that, oftentimes the scans are actually negative at these low PSAs, but as you get to higher PSA, you virtually always are finding something. The Condor trial was for Pylarify. It was their registration in the recurrent setting. Enrolled 200 patients across 13 sites. They mainly had BCR after radical prostatectomy. There was a minority with recurrence after radiation, and then the remainder recurrent after both. Primary endpoint was something called correct localization rate. They actually had a high detection rate. Lesions detected in about 59 to 66% of patients with a median PSA of 0.8. The correct localization rate ranged from 85 to 87%, and 2/3 of patients had a change in management based off results. So signifying it's a useful test that was changing management and was identifying disease in a fair number of patients. And the Spotlight trial was a single-arm registration trial for Posluma, 366 patients across 27 sites with BCR after radical prostatectomy, or focal therapy or radiation. The primary endpoints were verified detection rate and combined region-level positive predictive value. Performance goals for the lower bound of 95% confidence interval was 22.5 and 82.5% for specificity, so similar to the Lighthouse study. Lesions were found in 83% of patients with a high median PSA, and patient-level verified detection rate was 57% with a combined region-level PPV of 60%. So this is the commentary for the Spotlight trial. Had a very nice table kind of summarizing these different registration studies for PSMA-based tracers in the BCR space. So you have the UCSF, UCLA with gallium-68. You have the Condor with Pylarify, and Spotlight with Posluma. And you can see that they have a pretty consistent breakdown. They did include post-radiation patients in all of these, post-surgery patients that have received radiation and then surgery. Median PSA was the highest in the UCSF study, lowest in the Condor trial. And overall, they have pretty similar, I would say, detection rates. Sensitivity, specificities were more or less similar. And I think positive predictive value using pathology was similar between the studies, a little bit higher in the Condor study, but overall pretty similar, and supporting the use of PSMA PET in this study, in this setting as a first-line test. Now at UCLA, we did do a randomized trial of PSMA PET. So in this study, patients who had a biochemical recurrence after radical prostatectomy and a PSMA greater than 0.1, so pretty low, and kind of had agreed to salvage radiation, were randomized in a 1 to 1.13 fashion to either standard care imaging, which included fluciclovine, or PSMA PET. And you can see there, we had patients in the control arm that dropped out because they wanted to go elsewhere to get a PSMA PET. At this time, this was a way to get a free PSMA PET. Possibly, and then in the intervention group, mostly everyone stayed on except for one patient dropping out due to COVID. So ending up with a pretty sizable cohort of 185 patients. There was a slight imbalance in the median PSAs, 0.33 in the control arm, 0.23 in the intervention arm. And the primary endpoint is kind of event-free survival, but we also looked at changes in management. This enrolled patients from 2018 to August 2020. I don't want to spoil any results, but we should have a paper coming out soon looking at the changes in management from this study. But it'll be a little bit longer before we can get data on the event-free survival. But I think, hopefully it will help illuminate whether there's a change in outcome with incorporating PSMA PET in the salvage setting. So summary in this setting, obtaining an Axemin before salvage radiation improves event-free survival, even in a population with a median pre-radiation PSA of 0.34. PSMA has a greater detection rate than fluciclovine in the post-op setting for patients with PSAs ranging from 0.2 to 2.0. In rare cases, fluciclovine may have a better ability to detect prostate bed recurrences. We have 3 PSMA-based tracers in this setting with prospective data. And then of course, fluciclovine with the randomized data. And we have phase 3 data evaluating PSMA. They'll be forthcoming in the next couple of years, but hopefully the management changes should be coming out relatively soon. That's actually all I had. So it's a lot of time for questions. I'd like to thank you for hosting me, and I'd like to thank Dr. Jeremy Calais and Dr. Johannes Cernan at UCLA. They run our kind of PSMA program and nuclear medicine division, and I'd like to thank my colleagues at the UCLA GU Oncology team.
Thank you very much, Dr. Kishan. This was an excellent, very comprehensive talk highlighting the major trials that have taken place so far in the prostate cancer world space. Let me just quickly look at the chat box if there is any question. Otherwise, I can start with a question. All right, I don't see any. So as a radiation oncologist, Dr. Kishan, in patients with biochemical recurrence after definitive treatment in the past for prostate cancer and finding a negative PSMA or Axemin PET imaging, do you treat these patients, and do the dose of radiation therapy varies between those, or you don't treat those patients and you just follow them with ADT?
So, and you're talking about patients who have a recurrence after definitive radiotherapy?
Definitive treatment, whether it could be radiotherapy, radical prostatectomy, patients developing biochemical recurrence, but negative molecular imaging.
Sure. It's a good question. I would say this. I think salvage ADT is not a good option for these patients. We actually do have, prospective randomized data that immediate ADT just for recurrence doesn't improve survival outcomes as opposed to delayed. In that setting, recurrence after primary treatment, the TOAD trial, and there was also the ELAT trial from Canada. So I wouldn't go in that direction. So definitely don't recommend salvage. Now, it is possible that there's no harm in waiting, right? That it's theoretically possible that following the patients and imaging and treating if something shows up would not harm the patient. But I wouldn't recommend that, because at this point, we do have a lot of data from people who have been treated with post-prostatectomy radiation over the years that it's an effective treatment. And with better radiation technology, it's relatively low morbidity, all things considered. And we know it's more effective when the disease is treated at a lower PSA. And the way I explain this to my patients, because this comes up all the time, and I've had this discussion with referring physicians, if we opt to follow rather, and it shows up at a higher PSA, right, all we have accomplished is letting the cancer grow to a greater number of cells. It's a bigger cancer, so the treatment is going to be less effective. It may need the addition of hormone therapy, and you didn't really gain anything by doing that. Yes, if it shows some disease outside the prostate bed, then maybe you would have gained something, possibly, right? But we already know the sensitivity of the PSMA PET is not that high. There's no guarantee if you wait and there's some node somewhere else that's positive that there isn't also something in the prostate bed. We don't know those things. So at this point, I would say that would be a great trial to do, a randomized trial. I think it would be hard to do because patients may not feel comfortable enrolling on that trial, and physicians may not feel comfortable. But at this point, I would not avoid, or I would not recommend avoiding salvage simply because the PSMA PET or Axemin PET is negative in the post-prostatectomy setting. Post-radiation setting is a little different because their local salvage, we're just coming to understand the effectiveness. The morbidity may be different, generally an older patient population as well. So there, I think it's more reasonable if you cannot localize the disease to not treat. I think in the post radiation setting, you really need to see something in the prostate to offer local salvage in the prostate, whether that's on an MRI or whatever. But that's a different consideration. So I would say post radiation, if there's no evidence of disease on standard or advanced imaging, don't treat. In the post-prostatectomy setting, no evidence of imaging, do treat the prostate bed in most cases.
And I believe that has a negative PSMA scan post-prostatectomy with biochemical recurrence has a better prognostic significance.
Yeah, exactly. Has a better prognosis after receipt of salvage radiotherapy. There's several studies looking at that.
As a follow-up to that, do you guys do a lot of or any oxymin now, or is it mostly PSMA? And if the PSMA is negative, do you do an oxymin subsequently to pick up any disease?
Yeah, great question. I would say it's basically virtually 100% in that latter scenario where we have a patient with an a patient with a PSA that's fairly high, like above 1 to 2 level. We're doing a PSMA PET and it doesn't show anything. We do an MRI of the prostate bed, doesn't show anything, and then we start to think, okay, the detection rate is pretty high at that PSA level. We're not seeing anything. Could it be something hiding near that prostate bed area where the bladder is obscuring the signal? Like we can try an Axemin. Could it be a rare tumor that's not expressing PSMA? Those are pretty rare, right? But it's almost always in that type of situation. Otherwise, we would, like for a low PSMA PET being negative, we wouldn't jump to the Axemin. It's really in the high PSA where we'd expect the PSMA to show something and it doesn't, then we may consider an Axemin.
Piggybacking on the same question, and then I'll take Dr. Halkar's question. So as Dr. Takalkar mentioned, right, going back and doing Axemin to better evaluate the prostate bed. That's, as a nuclear physician, I sometimes struggle reading those PSMA scans, which are negative, but creeping up PSA, and I hate to hedge, but then I have to hedge in my report that because of too much intense overlying bladder activity, it may obscure anything in the prostate bed. Would moving towards post-loma, and as you showed in the Spotlight trial, they definitely had better detection, 68% compared to 34-38% with that you showed in the Condor or the UCSF UCLA trial. Do you think post-loma will change? The management will be more one-stop, imaging modality where you can easily see the prostate bed with less bladder activity, and then, sensitivity for the rest of the body is also better.
Yeah, that's a great point. I think based on the data alone, it seems like that could be the case, but I'll just be honest, we haven't gotten post-loma, so I haven't ever, we just don't use it here. There's some discussions about, maybe getting it or not, but it could be, that could be the role where it's, most helpful is in the prostate bed. I would say probably our nuclear medicine folks have talked about, are there ways to, time the detection so that even with Pylarify, it's okay to try to distinguish from the bladder and all that. But yeah, that would be the role, I think, for post-loma in the prostate bed.
And Dr. Takalkar, I and Dr. Halkar are from Emory, so Axemin, we are very it's very close to our heart. It's where it was developed. But definitely, as we'll get more information. So I'll quickly jump to Dr. Halkar's question. Genetic info and available targets are often used in most of the cancers now. However, in most prostate cancer, we still use Gleason and PSA for risk management. Is there any move to go for genetic analysis in prostate cancer?
Yeah, there's a big move towards these types of prognostic biomarkers and potentially even predictive biomarkers in localized prostate cancer. The difficulty is kind of given the natural history of prostate cancer, it can be hard to prove that something truly is prognostic and or predictive in a phase 3 randomized trial. It already cure rates are pretty good in many patients, and there's salvage therapy, so it's complicated. But I would say, in my institution, we do use tests like the Decipher test, so we use that one fairly frequently. We have published that the Decipher score does correlate with the risk of PSMA upstaging, and we're working on a paper right now that it may also correlate with the PSMA detected extraprostatic disease as well. So I think the Decipher score is one that can be helpful. And I think there's more data for that because it's built into some of the trials and has been validated in radiation trials. There's also, the cell cycle proliferation score and Polaris, Oncotype, DX. So there's a push to move towards these things. There's also kind of digital histopathology with Artera, I believe, just getting Medicare approval like a couple of days ago. So it's an exciting era. We're trying to move towards that, but it's difficult to really produce high-level evidence for some of these things.
Thank you. Dr. Akshay Sood's questions. Thank you, Dr. Kishan, for the great talk. Would love to hear your thoughts on use of PSMA scan in guiding primary therapy, BT boost or HR for prostate cancer, or focal therapy for.
Yeah, that's a good point, good question. So we and others have done kind of studies trying to compare the benefit relatively of multiparametric MRI versus PSMA, and I think they generally provide complementary information. So I do use it personally in radiation planning. So what we've moved towards in the radiation setting is maybe delivering what's called a focal boost. We treat the dominant intraprostatic lesion to a higher dose than the rest of the prostate. And generally, I try to bring in both an MRI and a PSMA PET if I have it to try to, boost that area to a higher dose of radiation. I'm not as much doing kind of focal therapy, so I can't speak to that. But in terms of the definitive radiation, I'm using the PSMA to help guide boost volumes. And our brachytherapy team still is doing a lot of whole gland boost because I think it can be hard when you're in the OR to just implant this area, but there's a push to move towards that with focal brachytherapy boosts as well.
Thank you.
Follow up to that thing actually. So you showed some good data on primary, the effect of PSMA imaging in primary management. And, when Oxymin was first approved, it was only approved for the subsequent treatment strategy setting, not for initial treatment strategy. And when PSMA-based tracers were approved, we were hopeful that we will do a lot more of the initial staging scans. But seems like our urology colleagues don't seem to see that much benefit. And what we are seeing is utility or usage only in the high risk or the unfavorable intermediate grade risk kind of patients. We're not seeing a lot in the favorable or the low risk. Any thoughts on that? You seem to think that it helps. I don't know if you have separation based on those groups, or do we need data?
Yeah, for sure. No, I actually would only really recommend it in unfavorable intermediate risk or higher. I think the chance of a favorable intermediate risk showing any meaningful change is pretty low. I mean, if we're talking about, if it happens to have been done, would I use it in planning and mapping out that dominant nodule boost? Yeah, I would use it for that purpose. But if I'm seeing a patient in consultation, I wouldn't recommend the PSMA PET for a favorable intermediate risk disease patient. Unfavorable intermediate risk, even there, that I think the chance of upstaging specifically in that group is pretty low, but it's reasonable to consider. In fact, as many of you probably know, this is at this point oftentimes driven by the patient. The patient comes in, they say, "Oh, look, there's this new PET that's available for prostate cancer. Can I have it?" And what can you say, right? I mean, if it's covered by their insurance. But if anything, the overuse for that kind of does dilute things and makes it harder for the patients that may actually need it to get scheduled, because now PSMA PET's booking 3-4 weeks out, right? And many of the people that are getting it are, probably don't need it. So I don't think it's necessary for favorable intermediate risk or low risk, certainly. And unfavorable to risk, even in then, I'm very comfortable proceeding without it. I think for high risk, it's worth it to get.
Yeah, but that's more for detecting disease outside the prostate bed.
Correct.
Does it affect your planning in favorable?
It shouldn't because it might add a little bit. It might add a little bit of information to the MP-MRI, but not enough to warrant getting the scan just for that purpose, in my opinion.
And do you happen to have a PET-MR, access to PET-MR at UCLA?
We're trying to get. We don't have it yet. We've been talking about it for a couple of years.
Yeah, I was going to ask.
This is Raghu Halkar. In NOPER study, we had always used in terms of change in management, and most of our PET approval for many malignancies was based on NOPR study. But I don't think PSMA went through or the Exumen went through that NOPER study. So most of the data is about sensitivity, specificity, rather than how much the management changed by introducing any one of the image. Maybe Medicare would do something like that to answer your question, Amol, about in the initial stage, initial assessment of prostate cancer, because ultimately whether does it change the management is the key issue. And sensitivity, specificity are great tools to identify what is good and what it is, but they do not directly reflect the change in the management.
Yeah, I think that would be a good study if CMS, because it's all comes down to payment finally, or unless the one of the vendors wants to sponsor that kind of a study, it would be good. But on another note, this may not be directly applicable to you, but a lot of like at least in other countries, they're doing a lot more PSMA guided biopsies now instead of the traditional biopsies with MR guidance and all that. For example, in certain centers in India now, about 80% of the prostate biopsies are now PSMA PET guided rather than traditional. It's very extremely few centers in the US are doing it. I think maybe Sloan Kettering may be one of the few places that does it in the US. Any thoughts on that? Because that may have implications on management as well, I believe.
Yeah, I mean, I don't have as many thoughts on that in the upfront setting, because I think part of that probably is related to access to PSMA PET scanning versus to MRI guided by, the uptake of MRI, right? Rather than actually the fact that it's better than MRI. I think one place that I do think it's very valuable is in the post-radiation recurrence setting. There, I think it's very informative and helpful to have the PSMA PET maybe in the MRI is very hard to interpret in that setting. So it was a PSMA, but at least that helps. And in that setting, we kind of require a PSMA and an MRI, and our team does a fusion biopsy. So that's like the post-recurrence consideration for local salvage, post-radiation, I should say, recurrence. But in the upfront setting, I'm not as sure the benefit that would have over our conventional pathways. I think it would limit severely access to PSMA PETs, because if we start doing that to guide biopsies, there'll be 3 months delay for patients.
I guess our Indian colleagues need to publish that data and show what the difference is. So hopefully that would be useful. There's another question in the chat by Dr. Subhash Keruka. Why not we use F18 PSA instead of gallium-16 PSMA to avoid urinary bladder activity? Yeah,
so I mean, I think that's part of. I mean, F18 PSMA, presumably the Posluma, that's the benefit of that tracer. In theory. However, I think sometimes the decision to adopt, gallium-68 in the US anyway, is just on the resources that have been placed into building that program. So we have that reactor, have had it for many years, and have been using it for many, many years, thousands of scans. So the nuclear medicine team just wanted to stick with gallium-68 PSMA at our main UCLA hospital site. The rest of the UCLA nuclear medicine facilities actually do use the pylarify tracer, but just because of the resources that are put into building the kind of locomets or, gallium-68 scanners and production, et cetera. At UCLA, we're sticking with that at the main site. But that's probably unique to UCLA and UCSF, which have the approval. Probably everyone else is using Pylarify PSMA.
It's hit and miss. I mean, we switch and PYL. It's not that it does not have bladder activity either. It does have bladder activity. Even with Posluma, there is some bladder activity. It's not absent bladder activity. In fact, we maybe implement. So we have used Posluma here in development phase, and now we are implementing it clinically as well. And our protocol would be to use Lasix with it to decrease the bladder activity even further, and see if that helps. So it's not that F18 based tracers don't have bladder activity either. But in general, we seem to be harping a lot on that. How important is this bladder activity issue? From your perspective, it doesn't seem to change management that much. If we miss it, you're just going to observe it for a little bit, kind of a thing, right?
Yeah, I don't think it would change management significantly. It becomes something we think about more if multiple scans are negative and the PSA is rising, and we would have expected to see something, and then we consider these things of could it be hiding near the bladder. It's not the first thing. If a patient with a PSA of 0.2 gets a PSMA PET and it's negative, I'm not going to think, oh, it's a recurrence that's near the bladder neck that we just can't see. You're going to just think it's subclinical disease. It's occult even on PSMA because the PSA is so low. So it's really in the case where we would be expecting to see something with a more high probability, and we don't, that we start thinking, could it be, something else to look at? And honestly, in those cases, I do jump to an MRI of the prostate bed, because there's data from Europe on using that to guide salvage radiotherapy, and so I jump to that first before thinking about another tracer. But if they were readily available, maybe we just get another PSMA.
I think in an ideal setting, a PSMA agent with the least bladder excretion, I think there are some that have lower bladder activity than others. And instead of a PET CT, a PET MR with that, it would probably win the battle. But we have ideal situations. We have to do with what we do. Changing gears a little bit, you didn't touch on this. It was not the focus of the talk, but talking about PSMA-based therapies, Pluvicto and all that. And there's a lot of interest by radiation oncologists in these radioligand therapies. What are your thoughts and where do you see that going?
Yeah, so I mean, the data from Vision and therapy were pretty exciting. I think therapy maybe had a little bit more of a consistent control arm treatment than the Vision trial, and that was one of the major criticisms of the Vision trial, was the management on the control arm. And I think that goes for the PSMA-4 trial as well, which was presented, I believe, at ESMO. And the SPLASH trial, which is with the PNT 2002 compound. However, I think it makes sense, right? It makes sense from a physics perspective and a biology perspective that there would be a role for this type of radioligand therapy. In fact, we just did a trial, just finished accruing in the oligometastatic setting, where we had basically the PNT 2002 compound plus SBRT versus SBRT alone in oligometastatic recurrent disease, because we thought it would be helpful. So I think the role is only going to expand, especially, presumably the PSMA-4 data, SPLASH data may move the use of these a little bit earlier in the therapeutic cycle. Probably, my bias would be that something like an alpha emitter would be more effective, particularly in the space where I most frequently treat patients, which would be the oligometastatic recurrent setting, where we're dealing with microscopic disease. I think the alpha emitter would be better. But it's an exciting time. It's enhanced our collaboration with nuclear medicine. So the data look compelling. There are some limitations to the trials, though.
Yeah, I mean, so we just starting doing the experimental therapies with alpha for neuroendocrine tumors with actinium dotatate in the US. I think we are lagging behind Europe and Asia, where they're doing this a lot more clinically. So I think it will be a few years till we start getting actinium-based PSMA therapies in the US. But we've done a fair number of Pluvictos, and several of our patients have completed all 6 cycles as well. And anecdotally, what we are seeing is a patient who have bone predominant disease in the metastatic setting. They don't tend to respond as well as patients who have more of nodal disease in the recurrent setting. Any thoughts about why that may be happening, and should we maybe use Xofigo first in that setting and then go to PSMA when needed, when there's more visceral disease, or maybe use a radiosensitizer kind of a thing that we use with other radiation therapies? Any thoughts on that?
Yeah, I mean, it could certainly just be that if, for whatever reason, Xofigo as an alpha emitting therapy and the calcimimetic is getting better dose around the bone area. I mean, that was actually also the basis of another trial called the Ravens trial, where they looked at people that had bone positive oligometastatic prostate cancer, kind of SBRT plus radium-223. The idea that maybe there's some bone tropism to this disease, and if it's seeded a bone before, it's more likely to recur in an osseous area. Whereas the nodes, there are some node-only recurrences, less burden of disease, so that might explain part of that. So that basically the alpha-emitting nature of the Xofigo plus the bone-tropic nature of the disease may explain why we're seeing that difference. We have seen that as well. So I think it is a real effect.
So I think we need more work than that. A couple more questions. Let's go with the first one by Dr. Keruka again. Why not lutetium-177 PSMA for diagnostic tool when it is concentrated in the prostate? Do you want to take that? It's more in our domain, but I'll be happy to hear your thoughts on that.
I mean, I would say that it's as a beta emitter kind of therapeutic tool. I don't know that it would be as helpful compared to like an actual diagnostic PET imaging agent, and it may just lead to dosing to that area that complicates further treatment.
It's the same thing like with I-131, right? It can cause stunning, and plus it's difficult to image small amounts of beta. We do bremsstrahling for larger amounts of lutetium when we do our Y90. But I don't think it will be a good sensitivity with just lutetium alone for as an imaging agent, since it's mostly a beta.
Yeah, the gamma flux of lutetium is low.
Very low, yeah. So it's going to not be very useful. Dr. Halker's question next is, what are your thoughts about when to use FDG or dotatate, knowing well that neuroendocrine and small cell are rare in prostate? When and how to suspect neuroendocrine differentiation in the follow-up?
Yeah, that's a great question. So I think we tend to think more about that in more castrate-resistant later stage prostate cancer, where clinically it appears maybe there's some neuroendocrine differentiation, and there's data suggesting that even up to 1/3 of these patients could have PSMA cold FDG avid lesions. And so kind of in a situation like that, very aggressive pace of disease, we do get a complementary FDG PET. We haven't used dotatate, but we do get the FDG PETs where there's any suspicion of that. So more kind of the castrate-resistant, metastatic castrate-resistant setting.
Yeah, I've been curious about the neuroendocrine differentiation as well. I don't know if it is high-grade neuroendocrine differentiation or low-grade, because I haven't seen a lot of dotatate positive end-stage prostate cancer scans. I don't know if it's a high-grade differentiation with a high Ki-67 value that makes dotatate scans negative in these. Something that's food for thought, I guess. Any other questions in the audience, from the audience live? I guess not, and it's right on the dot at 11 o'clock, so perfect timing. Thank you, everybody. Wish you all a happy new year. It was a fantastic start to our 2024 webinar series by Dr. Amar Kishan.
I have one word, yeah. This is Jyotsna.
Hey,
yeah,
Jyotsna.
sorry, I couldn't. I had a family commitment, so I joined in very late.
No
I'd
worries.
like to thank Amar a lot for accepting the invitation, and I'll listen to the recording. I wanted to thank him personally. Yes.
Awesome.
Oh, that's very kind of you.
Thank you,
Thank you.
Jyotsna. And thank you everybody for joining. It was a great start to our 2024 webinar series, and we look forward to many more. Happy New Year to everybody, and enjoy the rest of the weekend. And thank you, Dr. Kishan. We will be uploading the talk, and we'll be sending you a link as well. Have a great
All right. Take care. Happy New Year.
Happy New Year.
Bye. Thank you.